Hello. Thank you for joining. So I'm getting ready to start here and I'm sitting like on the ground and I just put up this baby gate because the dogs kept going upstairs and going to the bathroom, and I just want to you. This is my view right now. Through the baby gate. There's Mac. He really wants to participate. And Tosh is back there, but he's so dark you can't see him. Alright, so I'll get started. I just think it's really funny that Mac is literally right here. Okay, so thanks guys for joining. Let me just move this a little. Okay, yeah, kind of a weird location in my house, but it's like the best lighting. So the beer I'm trying today is called Secret Stash Stout, an ale brewed with vanilla. I know, sounds delicious. It's from Fitch's Beer Company in Chicago, Illinois. So once again, this beer was provided by Brew Public out of Charlotte. So love Brew Public. So I'm gonna get my beer ready to go. And today I'm gonna talk, oh my gosh, look how beautiful that looks. Vanilla porter. Ah. Yeah, yay Chicago. So my sister and John's sister both live in Chicago. And we're originally from about 2-3 hours south of Chicago, where the University of Illinois is. Did you hear that growl? That was Mac. He is so mad he can't join. Mac, do you want to join? Oh, sweet, a Neuro ICU nurse in Chicago. Cheers to you. And yay, Urbana. All right. Okay, Mac, do you want to come see everybody? You coming? No? Okay, so I'm going to go ahead and get started because I don't have a ton of battery, so I wasn't planning very well, so let me just try my beer and let me know what beers you guys have. Oh, I have a new favorite, I think. This is really good. Okay, so let's chat meds. I'm just going to do 3, but just kind of talk about, they're the big ones that are different than Neuro ICU. A lot of the Neuro ICU meds and critical care are pretty similar to the other meds, or the meds you get in the other units. So the first one I want to talk about is Mannitol. So Mannitol is an osmotic diuretic that is given for cerebral edema. Oh, and disclaimer, if I tell you anything that is different than what your policies and procedures at your hospital tell you, do that. That is what guides your practice. This is all informational stuff. So just a little disclaimer there. So Mannitol is used in the Neuro ICU to decrease ICP and cerebral edema. So it's this osmotic diuretic. So you increase the plasma osmolality and pull fluid off the brain into the vessels and then out. Oh, what's up? A peds nurse from Mexico? That's pretty awesome. Thanks for joining. So you're pulling fluid off of the brain and into the vessels, and it's a diuretic, so they're going to pee it out. It can be kind of hard on the kidneys, so you do want to watch the renal function. Try and pay attention to that too. An interesting fact I learned about Mannitol is that it's actually used a lot in the food industry. It naturally occurs in marine algae and crystallizing in the tubing. So one of the things that people know about, or that with Mannitol, is you have to give it through a filter set, and sometimes it's IV push, so a lot of times you'll get 12.5 to 25 grams every 6 hours, or sometimes you'll give it continuous, but I usually only give it IV push, so I draw it up in the vials with a blunt needle and then push it through a filter set, the ones that are like that long with a filter on it, and then I give it that way. Never ever not do that, it will hurt. And if you get a vial from the Pyxis, or if you get it from a Pyxis and it's been crystallized, send it back to the pharmacy and have them rewarm it, or get another vial. It's not like the med's not ruined, but you can't give it unless that has been crystallized, or the crystallizations have gone away. So that is the big thing. So you really want to watch you have to have it. Oh, you always give it continuous. I always give it IV push, and it's pretty nice that way. I don't know what other way. So basically Q6 hour BMPs Oh, my low battery. Sorry, guys. Okay, so Q6-hour BMPs, you want to really watch your serum sodium and usually a daily serum osmolality. So basically, you're increasing the serum osmolality, so you really want to watch to make sure you're not pushing it up too much and pulling too much off the brain, because then you can decrease the cerebral perfusion pressure and then cause even more damage. So you want to make sure you have your holding parameters. I really, I hope, when you're given Mannitol that it comes with an order set, but it doesn't, not necessarily every facility will have an order set for it. Yeah, I need to do that. I don't know how to block somebody. If anybody knows how to do that, I would appreciate it, because those comments are really inappropriate. I wonder if I can. Okay, I'll have to probably do that for the next one. So I apologize, guys, for those really inappropriate Okay, I'm gonna pay attention. Sorry, guys, I've never had that happen. Thank you. So basically, you want to make sure you have a daily serum osmo ordered, and the typical holding parameter is 320 to 330. My forehead is blocking the camera. So you want to make sure that you have this daily serum osmo ordered. Your normal serum osmo is 275 to 295, and you want to push it up, but you don't want to push it up too high. So 320, 330, make sure there's an order about when to notify the physician about this and when to hold it. And then your serum sodium is going to go up as well. So you want to make sure that you're holding it or calling the physician typically over 160, or if you see an increase more than 8 to 12 over a 24-hour period, and I'll talk about what that can indicate in a minute. So those are some really practical things. You make sure you're pushing it through if you're giving an IV push, you're doing it through a filter set, or you're drawing it up through a filter needle. I personally think it's a lot easier to draw it up with a blunt needle and then push it through a filter set. And you have your labs ordered and your holding parameters. And you really kind of want to watch your patients that have CHF or anything like that, because you're going to increase the cardiac output when you're pulling the fluid off and then, pushing it out. So you kind of want to watch people that have push over 2 minutes. Now, actually, there's so much of it that it's going to take you, even if you pushed as hard as you could, it will definitely take you more than 2 minutes to push it. I've not actually looked, but it definitely takes more than 2 minutes. So, and I usually get, the vials are typically 50 mils, so I'll get like a big 60 cc syringe and pull it out. And if you get it on your clothes, you get it on the counter, it's going to crystallize and be white. So don't spray yourself with it on accident. You're going to have to wash your clothes. So that's Mannitol. The next medication that I want to talk about, is 3% saline or hypertonic saline. That's another med frequently given. And it is used to treat hyponatremia naturally and cerebral edema as well. So I've had some, thank you. I've had some neurologists and neurosurgeons swear by Mannitol for cerebral edema, and some swear by 3%, and I'm not sure what the latest evidence says what is the best to treat it, but I've had both recently say that they go with this one's better. So 3% saline is something you want to definitely give through a line. My book is called Becoming Nursey. It's out on Amazon, or just search Kati Kleber on Amazon, it'll come up. So it's basically salt water, and you'll probably need a line if someone's going to be getting multiple doses of 3%. So a central line is pretty necessary, but keep in mind, if you have a patient that's probably only going to get one dose and they have big ropes for veins, and they're alert enough to let you know if they're getting phlebitis, then talk about it with the physician, because the risk of putting in a central line may not outweigh the benefits in that scenario. So use your clinical judgment and chat with your physician. Ultimately, they're going to make the call, but that's something to think about. But typically, if someone's needing 3%, they probably do need a line anyway. So I've only had that happen once or twice. So you're going to give this for hyponatremia. A lot of times it's pretty interesting how much, if you just give a little bit of salt, how it will affect their level of consciousness. So you have someone's out of it and really lethargic, and you give them a dose of 3% and they wake up all of a sudden. It's pretty interesting. So You want to make sure you have your serial labs ordered and holding parameters as well. Typically they can only order one bag at a time and have to reassess. That won't let them put in typically multiple orders of 3% is what I've seen. So the thing that you do want to watch out for is correcting it too quickly. And something, it's called CPM, or central pontine myelinolysis. I always say that wrong. So yeah, you got to draw your sodiums pretty frequently. It depends on how much they're getting, at what rate, but I think the least frequent that you can do when you're giving 3% is every 6 hours. But so you want to watch for a rapid increase of 10, I think the literature was not super consistent. Some said 8, some said 10 to 12. Increase in 24 hours. So what it does is it severely damages the myelin sheaths of the nerve cells in the brainstem. So it sounds very serious, and it is very serious. Like, you can kill somebody from raising their sodium too quickly with 3%. So you really have to watch. You can even, the extent of the damage really depends on how many axons were injured, but you can make somebody locked in. Like, you can give them locked in syndrome from messing up their sodium and increasing it too quickly. So if you're doing your Q2, your Q4, Q6 hour sodiums, make sure you're watching it. And it's up to you as the nurse to notice this, especially if, let's say, they came in with a serum sodium of 130 and it increases to 140. Well, 140 is in the normal range of 135 to 145, so lab's not going to call you and tell you, hey, your sodium's messed up. You're someone that you have to be able to notice that and let the physician know. I mean, when they round daily, they'll take a look at that, but that's something that's really important for you to be watching out for when you're giving 3%, is how quick the sodiums are jumping. And I encourage you to really look up, am I speaking too fast? Sorry. I really encourage you to look up the CPM, central pontine myelinolysis, I think. It's very interesting, and I mean, some people can have very mild symptoms, but some people can die, and it's solely from correcting that sodium too quickly. The third med I want to talk about is Propofol. That's something that's given in all the ICUs, but in Neuro ICU we can give it for a different reason. So obviously it's a sedative, and it's given to sedate patients, and it's not a pain medication. So I really want to stress that. It is, oh cool. Okay, I'll make sure I'll speak slower. I'm sorry. I speak really, really quickly sometimes, so I apologize. But thank you for joining from Brazil. So with Propofol, one of the reasons we give it in the Neuro ICU is for patients that are having continuous seizures that are not controlled by other medications. So one of the okay, this is getting pretty serious things is we've given them a ton of Ativan, we've given them Versed, we've given them whatever. All right, we're going to have to give them Propofol and intubate them just to suppress their seizures. And so that's getting pretty serious. So that when someone is getting Propofol for that purpose, you cannot titrate it. So I know most of the other times, or I can't think of any other time where you're giving somebody Propofol, the order typically says to titrate. So you can change how much you need, because their needs will change because they do acclimate to Propofol. But with these patients that are getting continuous EEG and they're having seizures continuously, you really want to make sure that you are not screwing with that rate until the physician tells you to, because they're basing how much Propofol they're giving off of what the EEG is showing. So if you're just screwing around with it, like you floated there and you're like, oh, okay, it seemed like they're tolerating the tube fine and there's too much Propofol, I'm gonna knock it down. You really can't do that. You really have to take a look at the last note from the neurologist and do it like that. So that is a really important thing to remember with Propofol when you're giving it for patients that are getting continuous EEGs. And pay attention and take a look and see if there's an order. If they're getting Propofol for that purpose, chances are they do not want you stopping it or pausing it to get a neuro assessment, because you want to get those seizures controlled. And if you're having to bump up the Propofol and you turn it off just for an assessment, that's going to screw up the progress that you've made. So typically there's an order in there that'll say not to turn it off or pause it for assessment. So make sure you're paying attention and taking a look at those orders. It's weight-based. Make sure there's an accurate weight in the chart. The tubing gets changed every 12 hours. So if you're coming, that's one of the things when I'm getting report, I'm making sure I'm looking at my Propofol tubing, and if there's not, I think for seizure suppression, Propofol or Versed, I honestly, I can't answer that. I don't know personally. I've seen it, some work better on some patients and the other one work better on others, and I honestly can't speak to why some work better. I know I like giving Propofol better just because of the quick acting. You turn it on and it's working wonderfully in minutes, and then you turn it off and it's going away and you can get a good neuro assessment. So when you're getting report though, make sure you're looking at your Propofol tubing to make sure you know when to change it. It gets changed every 12 hours, so it will get changed during your shift. And if you don't know when the last time it was, you don't know when you need to do that. The content, what makes, I think there's a lot of fat in it, I believe, and that makes it so you have to change the tubing frequently. So another thing about Propofol too is, let's say the patient's not having seizures, but they are receiving Propofol for sedation. To do all your neuro assessments, you got to make sure you pause it and titrate it to clinical response. So patients that are on Propofol for days and days, they get acclimated to it, and they may need more, they may need less to achieve the desired effect. So make sure you're titrating to your clinical response. Hey, respiratory therapist. So basically, so this is what I've seen happen before. You press pause to get a neuro assessment, and then they're not really responding, so you don't really need to turn the Propofol back on, and you forget to flush the line for a little while. Well, Propofol will clog your tubing very, very quickly and screw up your lumen or your line or whatever it is. So I know that happens occasionally where you forget to flush something and you have it hooked up. Propofol is one you cannot do that with, because you're going to screw up that lumen. You're going to have to, deal with that other headache from forgetting and leaving the Propofol. So that's something that's really important to make sure that you're doing. So, and also because of the content of it, whenever you titrate it, that you're probably going to, especially someone that's on it for days and receiving tube feeding, you have to work with your dietitian, because they may be adjusting the rate based off of how much Propofol the patient is getting. Because there's so much fat in it, they have to balance it out with the enteral feeding. So I think those were all. Obviously you're watching for oversedation and hypotension with that. And keep in mind that Propofol is not a pain medication. So if you have a patient that has been in a trauma, like an accident, a fall or whatever, and you know that there's some underlying pain, like increasing their Propofol all the way up is not going to address that pain at all. I think a really good thing to do is like maybe 25 mics of fentanyl an hour, or whatever your pain protocol is, to make sure you're addressing that, because Propofol will not take care of pain. It's just going to knock them out. And so one of the things I did when I was new to critical care, I was floating to the regular ICU, and I had a patient that was there for a respiratory issue, and I can't remember what it was. But in neuro, a lot of our patients don't get fentanyl because it can affect their neuro exam. But, if you have a little bit of fentanyl going and you can really come down off your Propofol because you've got the pain relief, that's really beneficial. And you clear it with your neurosurgeons and your neurologist first, but it can really be beneficial to do that. So back to my little story. So my patient, I was like going up and up on my Propofol because that's what I knew how to do. And I was talking to the pharmacists, and they were like, you always want to make sure that you increase your pain medication before you increase your sedation. And I went in the room and I did that, and the patient, I could back off my Propofol so much, because I think I started a fentanyl drip. I got it up to, I think, 75 mics an hour, and then I was able to back off the Propofol a lot. So it's really important. People do forget that Propofol isn't a pain medication, and to leave them hanging with just Propofol for tube tolerance, that's, I would want, especially if I was in some sort of an accident and I've got legit pain, but I'm just knocked out, and the second you turn it off, I'm in excruciating pain. It's gonna make my recovery a lot more difficult, and your patient's recovery a lot more difficult. So it's something that's really important to remember. My other, let's see, I want to make sure. So my other thing about meds with the Neuro ICU is PRN medications, and this is true for all disciplines, I guess, is when you look at your PRN meds, you can only give them for what they're indicated for. So if my neuro example is you have Ativan PRN and it is written for seizures, but your patient's agitated and you have Ativan. So you can pull it, you can scan it, you can give it, it's not going to stop you at all. But if you're giving PRN Ativan written for seizures, but you're giving it for agitation, that's inappropriate. The physician probably really needs to know if your patient is so agitated it's requiring Ativan to control it. That can signify a neuro change that needs to be addressed. They really need to know that. And then if they come in the next day and overnight they got 3 doses, or yesterday maybe they got 3-4 doses of Ativan and they got it overnight, it looks like they've been seizing so much that they need multiple doses of Ativan. And when the physician should have been notified 24 hours ago that they're super agitated enough to justify giving Ativan, you know, that's a large gap of time between one thing and the next. So, and that's just a neuro example, but, you know, it's really important to make sure that, you know, legally you can't, as a nurse, you can't give any medication that is written for something that it's not indicated for. So like if you have labetalol and it says you can give it for over 160 and your patient's blood pressure is 150 and you're given labetalol, legally you can't do that. So it's something you really got to make sure, if you think you need a med, you got to make sure you call and get the order and put it in appropriately. Especially if someone's having changes and you think you need to give them Ativan, don't just pull the Ativan written for seizures. You got to make sure that the order says agitation or seizures or whatever. So those are my, I want to make sure it's something that was interesting I found out when I was looking up some information was Propofol is multiple states have actually tried to use Propofol for executions, but the manufacturer refuses to supply it for that need, which I thought was really interesting because that would be a very effective medication for that. Oh, and something else I do with Propofol. I always have patients and families inevitably say that's the Michael Jackson drug. Is my family going to die from getting the Michael Jackson drug? What I always tell them is Michael Jackson did not have a breathing tube in, and Propofol works wonderfully and beautifully if you have your breathing tube in. So that's, you know, it's very safe when the patient has that, but he didn't, and that's why he died. So that's, I've had to explain that many times, unfortunately. So those are my 3 medications I really wanted to go over. So your Mannitol filter set, make sure you're giving it through a filter set, it's not crystallized, and your orders are in for your serum sodiums and your plasma or serum osmos, and you're checking those before you're giving your doses. So that's your main things with your Mannitol. Hypertonic saline, same thing. You have your serial labs ordered. You're paying attention to those. In particular, your sodium, you're not letting that rise too quickly, and you're notifying the physician when you notice that. You probably need a central line if you're giving multiple doses of 3%, and making sure all your labs are in. And with Propofol, making sure that you're not pausing it, titrating it for patients that are in status, and continuous EEG monitoring. And you're really paying close attention to the order and the position note. And if you're giving it and your patient is not on it for continuous EEG and seizures, that you are flushing it when you pause it. If you're pausing it for an extended period of time, you're changing your tubing appropriately, and you're making sure your patient's pain is adequately controlled with the approval of your neurosurgeon, your neurologist, or whatever, whoever is managing that patient. You know, you want to make sure when you pause it, you can get a good neuro assessment. So just a little bit of fentanyl, 25 mics an hour of fentanyl theoretically should not sway their neuro exams so much that you can't tell how their brain is acting. It's just going to give them a little baseline pain relief. So that's a real good thing to suggest to the physician if you're noticing you're having to go up and up and up on your Propofol, just to get the patient baseline comfortable. A little bit of fentanyl, like a continuous 25 mics an hour really does a lot. So those are my nursing considerations for 3 neuro ICU meds. I wanted to see if anyone had any questions, or anyone that floats to neuro that's you're nervous about something in particular. If there's any specific questions to neuro ICU. Next week, I plan on talking about central lines and just some real basic stuff for people that are just getting into nursing, understanding what a central line is, why we have it, some really important things to know about central lines. It took me a little while to put all those pieces together when I started out on the floor about central lines. I'll give people, if they had any questions about Neuro ICU, medications, or any concerns. Great. Yeah, there's just some ways to explain central lines that I feel like I didn't really put the pieces together too until a little bit later. So give people a little time. Oh, good. I'm glad. Cardiac scares me. I've floated to the CCU, the coronary care intensive care unit, multiple times. They're very nice to me there. They don't give you the really tough ones like the patients with an impella and all that kind of stuff. But I do enjoy cardiac because I spent some time on a cardiac step down. But the one straight out of CV surgery, neuro can be scary, but once you know what you're doing, you get into a routine with your neuro exam and you kind of know when to be freaked out. It's awesome, I think. I love the brain. It's so interesting to me. No problem. My pleasure. Give people just a little bit longer if anyone had any questions while I finish enjoying my beer. Oh, wonderful. Rehab nurse, yay. Studying peds neuro. I don't know anything about children. I've had to go over to the pediatric intensive care to help them put in like a ventric and stuff. And oh yes, MTI. I wish I was going this year. I'm not, unfortunately. But man, going over the peds intensive care, especially now that I have a kid, I'm like, oh, thank you to all of you that do that. So, my pleasure. I'll hang out just a little longer if anyone has anything. And I have learned how to block people now, so I'll be more on top of that next time if I see that. I appreciate those of you that shared with me how to block people. Those comments were completely inappropriate, and I really apologize. Anybody else? Any questions? And maybe not even related to neuro or related to nursing. Any students out there have any questions or anything like that? I went through it a lot quicker than I did last time. Oh, it won't take long, let me tell you. Once you know what you're doing, it'll give her a year. She'll do wonderful. You get it's one thing I've learned about nursing is when you get into your niche and your role, you really learn all the ins and outs of that. And like, if you ask me something about children, I don't know anything about children. I do, well, I used to. Now I have my brain sheet memorized, so I write it on a blank sheet of paper so I don't have to find a report sheet, but I use one and I use a full sheet of paper for each, or I do the front and back, because typically I only have 2 patients in the Neuro ICU. But someone else asked me that recently, and I said I was going to draw it out. L&D nurse, oh great, doing great. What about gelling patients and learning ins and outs of charting? Oh man, so that is one thing that when you're new, if you can really focus on those charting classes they give you, I feel like the quicker you get your head around charting, the quicker you can take care of your patients. So meds and the Propofol. Yeah, I mean, these are just the main, the Propofol is given in a lot of critical care units, but just being aware of the implications with patients having seizures. But then Mannitol and Hypertonic saline are 3%. Those are the ones that are typically just given in the Neuro ICU and not typically given in the other critical care units. So I think it'd be good if you're floating there to know those. But when you're new and you're juggling stuff, it'll get easier. You'll walk in, be totally overwhelmed, and then all of a sudden one day you're going to get it and you're going to feel like you really know what you're doing. But charting is frustrating and difficult, but thankfully whenever you give a report, if you can just sit down, About the map 1 week. Oh, like mean arterial pressure? When you say map, is that what you mean? Or the brain sheet? Gosh, what question was I answering? No, it's totally fine. So do we use Mannitol as scheduled or PRN? So I don't know if I've ever used Mannitol as a PRN. I typically see an either one-time dose or every 6 hours, and they renew the order daily, and they look at the serum osmo every day and the Q6-hour BMPs, and they, you know, hold if blank and call. So if the serum sodium is over 160, the serum osmo is over 320, then I call and I get further orders. But usually I get like a day at a time. And if I come in and the patient's received 24 hours of Mannitol, I'm a little okay. Yes, I can talk about that. And actually, it'd be probably good for me to just show the brain sheet. And I think I might put one on the blog when I should do that. Someone else asked me that about neuro, so I will definitely do that. I need to put that on my to-do list. So yeah, it's typically scheduled, and then I'll ask, you know, the next day before I give the next dose, hey, do we want to keep doing this? Especially if our labs are getting pretty close to the upper limit, because they really typically don't get Mannitol many days in a row. It's just such an intense medication. Yeah, I have not like a scheduled daily dose of Mannitol. Really just a one time or Q6 times 4 doses. I've seen that before. Or maybe give 1 or 2 doses and then the physician will reassess the next day and reorder. Just really depends. It really depends on how sick the patient is too, because if you're giving Mannitol and you pull too much off and you really decrease the cerebral perfusion pressure, and then you have a whole nother set of issues on top of that. So those patients, I feel like it's like you said, like an emergency, or you're doing it every day. And I just got to show you guys this. So I'm sitting at the bottom of my stairs, and look at this. Look. I got my audience right here. Mac has checked out, and then Tosh just keeps coming up to see you guys. Your little tail going. Hey guys, my buds. A couple minutes for any more final, I gotta go sideways there. Any final questions, and then I'll go ahead and sign off, and thank you so much for joining me. I'm gonna do this again next week, but I think I'm gonna do it on Tuesday instead of on Monday. My maternity leave is officially completely over. Hannah is asleep. Hannah goes to bed at 8 p.m. now. Yep. She sleeps from 8 p.m. to 7 a.m. and with one feeding in between. So she's asleep. Otherwise, I would have her here so you could see her. But so next week I think I'm going to do Tuesday evening instead of Monday, because I'm working Sunday and I want to give myself a night off. So maternity leave is over, unfortunately. So, well, cheers to everybody. See, there's no more questions. Thank you guys so much for joining me, and we'll talk central line basics next week. Okay, guys? So thank you guys. Have such a great night. Thanks for joining me. No, I don't want to do a CRNA. I don't know why. That just being in the OR. Oh, well, that's okay. I will put it on my blog. So even if you won't be able to see it like live on Tuesday, I'm gonna have the notes on my blog with the video so you can see both. It's just, I don't think you'll be able to see all the comments though. That's the only thing, is you won't be able to see the comments. But Hannah is a wonderful baby, and no, I don't care at all no, don't worry about your English. I don't care at all. But no CRNA. That's, I don't know why that or NP. It just doesn't. I think if anything, I might go towards the educator role, or maybe a PhD in research. Thinking about those kind of things. I do love patient care, but I don't know why those just don't sound super. I don't know. I just don't really want to do that, I guess. I love those jobs. Those are wonderful jobs. It's just not something that I'm going to be interested in. I'm introduced an RN student who has the job, and Oh, wonderful! Yay! Thank you guys so much for anybody that's sharing these videos and my blog and stuff. I really appreciate it. I just want to make it so you guys have as easy of a transition from school to work and feel confident as quickly as possible, so that, oh good, I'm so glad. So that's my whole point with these and the blog. I just want it to be helpful and smooth, and you get to where you want to be as quickly as possible. You don't have that rough year like I did. So any way I can help, I will try to. It might take me a little while to get back to emails and whatnot, but given that I have a baby and no longer am on maternity leave, so but well, good, I'm glad. Thank you so much for sharing. Thank you guys so much for joining, and I hope you guys all have a wonderful, wonderful evening. Cheers. Have a good night, guys.